on the occasion of World Heart Day.
We have with us Dr. Sirshendu Paul from Siliguri.
So, Doctor, dyslipidemia के patients को कितनी बार अपनी कोलेस्ट्रॉल की जांच करानी चाहिए?
A patient suffering from dyslipidemia in a very uncontrolled should ideally first go for lifestyle modification along with that modification for the first 3 months. If he is not controlled for the first 3 months, then we go for medication. And initially, the lipid levels should be tested every 3 months for first 1 to 2 episodes. Once the lipid levels are relatively stable, we can go for measurements every 6 months. And once the targets are achieved, perhaps we can go for yearly testing also.
On the occasion of World Heart Day,
we have with us Dr. Sirshendu Paul from Siliguri.
So, Doctor, what is dyslipidemia और इसके कारण क्या हैं?
Dyslipidemia is a word which is perhaps self-explanatory. It means dyslipidemia. That means abnormality in the lipid levels of blood. And what are these lipids? Lipids are fat droplets. Fat droplets which may include cholesterol, cholesterol esters, triglycerides, and various things. And all these form the lipids. Abnormality in the lipid levels is described as dyslipidemia. Dyslipidemia has various causes. It may be primary or secondary. Primary dyslipidemia would include the ones which are familial, that is present from birth. It may be familial hypercholesterolemia, familial triglyceridemia, familial dysbutyrate lipoproteinemia, or familial combined hyperlipidemia. These are the various types of primary dyslipidemia. Amongst the secondary dyslipidemia, the commonest one is obesity. Next comes metabolic syndrome, the nephrotic syndrome, hypothyroidism, or atherosclerotic dyslipidemia. These are due to diseases, or even it may be from Cushing syndrome. These are diseases which increase the lipid levels in the blood and causes the dyslipidemia.
डॉक्टर, अपनी जीवन शैली के अनुसार पेशेंट को अपनी डाइट और एक्सरसाइज में क्या चेंजेस करने चाहिए जिससे उनका कोलेस्ट्रॉल सामान्य रहे?
First of all, we should modify the risk factors. The first one is smoking. Tobacco, we all know, increases lipid levels. Also, it's the number one risk factor, and one should quit smoking altogether. Quit tobacco altogether would be the better word, because very many Indians not only smoke, but some of them chew tobacco or take the pan or other local indigenous products. Next, the other diet. We should avoid red meat, which is very high in cholesterol, or egg yolks too many per week, or the prawns which are very high in cholesterol levels. Opposite to that, the oils which are used needs to be mentioned. Some of us of the opinion that we should always take the light oils that are unsaturated. That's perhaps not true. We should take balance of monosaturated, unsaturated, and the saturated oil. The best is a good, the best oil is one which has a good proportion of not only unsaturated fat, but also the monosaturated one and the polyunsaturated one. And a food cooked at a high temperature, it's perhaps judicious to use the monosaturated oil because it contains long-chain fatty acids, and when they break up into short chains and perhaps are beneficial to the body. But if you use the unsaturated at a high temperature, oil is destroyed and that's more harm than good. You should go for blending of oil. Blending of all oil or edible oil. The best oil for any atherosclerotic, diabetic or cardiac patient would be olive oil, closely followed by the rice bran oil, because these two oils contain a good proportion of not only polyunsaturated fat but also saturated fat. And we should take a big proportion of these two, which will be helpful to the body. And of course, we should remember that blending of oils is essential. Some exercise. Each individual suffering from any cardiovascular condition needs to exercise at least 30 minutes per day to a total of 150 minutes per week. And it will be better if you can put it 2 days of active exercises, not only walking, but 10 exercises like running or running stairs, so on and so forth. Also, these exercises which can be done for shorter intervals to derive the things and work for such a But per week, and teachers should ideally take each of 150 walk per week, these intervals of very active exercise temperatures or long, etc. It should be better for the individual.
So, doctor, what are the normal blood cholesterol, LDL, and HDL levels?
The normal lipid levels has a big variability. It depends on the not only on the age of the individual, but also whether the patient has risk factors. For example, a lipid of less than 190 would be dyslipidemic for any individual, but a level of say 160 may not be dyslipidemic for all individuals. That is, if we take the risk factors into consideration, then the other lipid levels vary. Also, the lipid levels vary a lot according to the age, also according to some diseases. For example, if a patient suffers from HIV, where all the lipid levels are usually low, especially the HDL which is very low. But a patient suffering from atherosclerosis may have many risk factors. For him, any LDL more than 70 mg per kL would be high. And for patients with multiple risk factors or patients who have had multiple events, there we try to reduce the LDL levels as low as possible. A patient with multiple levels, say more than 2 events or more in the past 2 years, should have an ideal level of less than 40 mg per kL. Any patient who is diabetic, which is considered as a coronary risk equivalent, should have an LDL of less than 70 mg per kL. A patient who has 2 risk factors or more should have an LDL of less than 100. Similarly, have levels for the other lipid parameters. Take the non-HDL level, that is the total cholesterol minus the LDL. That would be usually taken as 130 mg per kL. Anyone which is above that per kL will be considered as dyslipidemic, while not if it is less than 130. For HDL, the usual level is considered 35 to 40 mg per kL. For males, for ladies, it's more. It should be more than 50 mg per kL, or maybe in some cases, or Europeans, it may be more than 60 mg per kL. Thus, you can find that the lipid levels increase not only according to the disease of the patient involved, but also according to the sex, also according to risk factors. The triglycerides are usually very high in our Indian or South Asian population. The normal triglyceride level would be anything less than 150 mg per kL. Here, level of 200 is a mild elevation. Till the level of 200, we may control it only through that modification. Anything more than 200 would be a moderate elevation, 200 to 400, and anything more than 400 is for the triglyceride to be considered as very high and needs not only diet but also modification. The VLDL is usually taken as 1/5 of triglycerides, provided the total triglyceride level is less than 400 mg per kL according to Friedland's equation. However, this equation doesn't stand good if the triglyceride level is very high and more than 400 mg per kL, and then you have to calculate the LDL separately. Also, for these lipids, we should remember that ideally it's taken in fasting state, but it's not required for perhaps for LDL or for HDL, only the triglycerides which are raised following these, and VLDL subsequently which breaks up from triglyceride is also raised following these. The rest of the lipid parameters can be done in non-fasting state, and nowadays we do not insist on the non-fasting lipid levels as the usual cardiac markers like LDL, HDL or the HDL cholesterol levels are not altered through food intake and are non-fasting levels perhaps suffice.
So, doctor, what are the common classes of drugs used for the treatment of dyslipidemia, and how are they beneficial?
These drugs are used to reduce our cholesterol levels. They fall into the following categories. The first one is the HNG reductase inhibitor or the statin. This is followed by the fibrates or the phasic acid derivatives. Then we have the bile acid derivatives or bile acid sequestrants. We have fourth one nicotinic acid resistance. And finally, we have drugs which have other mode of actions, reducing triglyceride levels or reducing absorption of cholesterol. The miscellaneous drugs which include the ezetimibe. And last but not least, the PCSK9 inhibitors, that radiomirchi, which are used when LDL cannot be reduced with the high dose of statins or ezetimibe. Using all those targets cannot achieve, especially in cases of familial hypertension also, may use the PCSK9 inhibitors. Now coming to the statins, the glucocorticoid coenzyme A reductase inhibitors, they mainly act on the LDL, they reduce the LDL, and perhaps the drug which is used the most is the first line drug. Any person having an even should be put on a statin, and on a high intensity statin if there is an even or there are a number of risk factors. The statin helps to reduce the LDL levels, and not only do they reduce the LDL levels, they also do reduce the triglyceride levels to some extent. Some of the statins reduce the HDL cholesterol levels also, which is perhaps not desirable, but rosuvastatin is perhaps neutral or may even increase the HDL cholesterol levels. There is a fear that statins may reduce impaired glucose tolerance. However, that's not an hindrance to prescribing statins, considering the risk-benefit ratio for each patient, and perhaps statins nowadays prescribed for any diabetic patient is more than 40 years, as diabetes is considered a cardiac risk equivalent. Next we come to fibrate or the fibric acid derivative. Now, in population of the South Asians, the triglycerides are often very high and cannot be controlled or may not be controlled statins alone. Then you need to add fibrate to reduce the triglyceride levels, or it may increase the HDL levels also to some extent. However, fibric acid derivatives cannot be used in patients with renal compromise. There we have to stick to statins alone. Finally, third, we have the nicotinic acid or niacin, which are very little used nowadays. Formerly it was used mainly to increase the HDL levels. However, it has been proved that HDL perhaps that improves through exercise, and increase exercise to increase the HDL levels also through lifestyle modification. Also further, nicotinic acid or niacin very often causes flushing, and the drug is intolerable to many patients. So nowadays, nicotinic acid or niacin are very rarely used. Bile acid systems, cholesterol or cholesterol are very rarely used because they cause diarrhea, they cause intestinal malabsorption, and bile acid systems are also not easily used in our armamentarium unless the patient is intolerant to statins by medicine, so on and so forth. Finally, we have another molecule, the ezetimibe, which causes inhibition of the intestinal absorption of cholesterol, thus reducing the total cholesterol. It may be given along with statins to reduce LDL levels. Also, the high dose of statins may cause side effects, for example, myalgia, nervous in some patients, or even liver problems. In such cases, using a small dose of statins, ezetimibe may help us to control the dyslipidemia. It gives us cholesterol absorption, also reduces the triglyceride synthesis, and may help to control the lipid levels. Finally, in very rare cases, for example, familial combined hyperlipidemia, hypertriglyceridemia, or severe dyslipidemia, not responding to any drug, we have a new drug in our armamentarium today, that's the PCSK9 inhibitor.